Hello, everyone. My name is Joanne Davis, and I'm the Executive Director of the Radiosurgery Society. I want to thank you all for joining us for today's webinar, which will be addressing two exciting topics. The first title is Our Journey to Safely Deliver Dose-Escalated SABR for Pancreas Cancer. And the second is Improved Accuracy and Efficiency in Hypofractionated Pelvis Treatments using Surface-Guided Radiation Therapy. We'd like to acknowledge and thank Vision RT, who is supporting this webinar through an unrestricted grant. Our webinars are free and open for anyone to attend. CME certificates are available for those attending our live webinar broadcasts and are at no cost to our RSS members. CMEs are available to non-members for $19.95. Everyone attending today's broadcast will receive an email with follow-up instructions on how to obtain CME certificates. During today's presentation, you can submit your questions by clicking on the questions box located in your GoToWebinar window. Please submit questions at any time during the presentation, and questions will be addressed at the end of the session. Now let's get started for today's webinar. It is with my great pleasure to introduce you to our moderator, Dr. Laila Chalebi. Dr. Chalebi is a radiation oncologist at Northern Westchester Hospital and Phillips Hospital, and is an associate professor of radiation medicine at the Zucker School of Medicine in New York. She graduated from NYU School of Medicine and completed her residency at the New York Presbyterian Brooklyn Methodist Hospital. Her research is focused on gastrointestinal GI oncology and radiation oncology. She's contributed her insights to guidelines on the treatment of several GI cancers, including pancreas, stomach, and hepatobiliary. She has wrote international guidelines on managing GI patients, including and during COVID. She's involved in several national committees and organizations, including the American Radium Society GI Committee, ASTRO's Multidisciplinary Quality Assurance Committee, and the NRG Oncology GI Committee. It is with my great pleasure to welcome Dr. Chalebi. Dr. Chalebi, take it away.
Thank you. Thanks so much for that warm introduction. I will introduce both of our speakers up front so we don't have to take a break in between the two presentations. Our first speaker today is Dr. Todd Aguilera. Dr. Aguilera is a co-director of the Interdisciplinary Pancreatic Cancer Program at UT Southwestern. He specializes in stereotactic ablative body radiation for pancreatic cancer of localized and metastatic disease. This includes employing new technologies to safely deliver dose-escalated treatments to patients in the adaptive radiotherapy era. Dr. Aguilera was recruited to the Department of Radiation Oncology at UT Southwestern to establish his research group, which will continue to investigate the immune microenvironment and engineer approaches to target cells and molecules that lead to immune privilege. He treats radiation oncology patients with gastrointestinal cancers, is developing laboratory projects in pancreatic cancer, and aims to establish collaborative projects with clinicians and researchers. Our second speaker for today, Dr. Daniel Bailey, completed his graduate degrees in clinical residency through the physics department at the State University of New York at Buffalo in collaboration with the medical physics program at the Roswell Park Cancer Institute, also in Buffalo. Dan is actively involved in the AAPM, AAMD, and the ABR professional organizations, and is currently the Director of Physics and Dosimetry for Sarah Cannon, the Cancer Institute of HCA Healthcare. His research and clinical improvement activities include SRS, SBRT, SGRT, quality assurance, and dosimetry techniques, total body radiation, and improving the quality and safety of the modern radiotherapy workflow. We look forward to hearing your presentations. Dr. Aguilera, please go ahead.
Excellent. I believe everyone can hear me, and I will start sharing my screen right now. Okay, perfect. Well, thank you so much for the very warm introduction. It's such a pleasure to be in this venue. I got pulled out of lab for this, which is great. I'm excited to share a little bit about our journey over the last years in treating pancreas cancer with SABR. So this is a little bit of the agenda for today and how we envision transforming pancreas cancer care with radiation. I'll talk a bit about the current state. That will highlight kind of the playbook that we've used as well as the technology and key lessons from surface-guided radiation therapy. And if we have time, I'll talk a little bit about the future state of where we're going in pancreatic cancer, from adaptive therapy to personalized radiation. So just a brief background on myself. I appreciate that introduction. I'm usually in the scientific circles, but also clinically active. So I just thought I would give some perspective of kind of where my other 80% of my job lies. We're very interested in my group of targeting the tumor microenvironment and translating that into the clinic. We have two different directions of our research lab. One works in molecular engineering to develop the next generation therapeutics, particularly for targeting the immune system. And then we're also studying the tumor microenvironment with therapeutic responses, which is very relevant to what we do, because we want to understand what happens to tumors after we do radiation. And we really like to understand gastrointestinal cancers and how to improve immune targeting and maximizing radiation therapy. So the topic for today is pancreatic cancer, and it's not a surprise to anyone when they hear that the outcomes are poor. This is about 60,000 patients are diagnosed every year. And even though it's not the most common cancer, the second most common cancer, with the latest data suggests that sometime in the next 2 years, probably, it will become the second leading cause of cancer-related death. However, I would say there is hope. Even in the last few years, basically yearly, there's about a 0.5% or 1% increase in the survival. And a lot of this may be attributed to increased investment, but also how we have really transformed what we're doing in the clinic and not thinking about this disease with as much nihilism as maybe once had in the past. So my patients today, in 8 years, they may have a survival of 20% living 5 years. So we'll see, and we hope that we can make that happen. I oftentimes say, with the survival at 13% or 10% or whatever, we can triple the survival and have a long way to go, where for a lot of other cancers, you can't even triple the survival because it's quite high. So this is one of the reasons why it's such a privilege to work with this disease, because I believe we will see a lot of transformation in the years to come. There's a lot of challenges, but of course, certainly progress. So I'm showing kind of this diagram right here to give an idea of how the percentage of patients that are diagnosed at different stages of the disease. Resectable, it's only about 10 to 20%. Locally advanced, unresectable, about 30 to 40%. And 50 to 60% have metastatic disease at diagnosis. And you can see the median survival, this is old data, is not so great. But of course, if we can get to surgery, whether it's locally advanced or resectable population, patients can be cured of this disease. And there's been a lot of advances that have really helped us. With systemic therapy, we are thinking very differently because patients can live a long time. Gemcitabine and Abraxane in 2013 and FOLFIRINOX in 2011 have been incredible advancements. We're also evolving how we're doing radiation therapy, which I'll talk about. And surgery has also evolved. As the chemotherapy has gotten better, then surgery has become more creative, particularly with robotic surgery, and cautiously aggressive, which is making real impacts. I believe radiation actually plays a role in all these settings. However, it varies a lot in terms of how well substantiated it is. So it's critical that we develop level 1 evidence. So I'll tell a little bit about why is Pancreas SABR useful and in who, just as kind of a little bit of a background. We believe that it is useful in the resectable population, though we don't commonly treat it at our institution. You can do this as neoadjuvant, and the complications are low and it's quite safe. It is standard at several institutions. And the reason why this might matter is because a lot of patients have LVI and PNI, so lymphovascular invasion and perineural invasion. Therefore, a high risk of local recurrence. And what we found from one of the more modern trials, SPAC4, is that 50% of the patients that failed only with local disease. This was an adjuvant chemotherapy trial that did not include radiation therapy. And it was about 10% where it was both local and distant, and 40 failed distant. So local is still a big problem. In the borderline and locally advanced setting, you can do neoadjuvant treatment, and SABR may reduce the rate of local failure after surgery. And this is an area of a lot of interest and dose escalation, which I'll talk a bit about today. This also goes along with the unresectable patients. And we know that for patients who cannot have their pancreas tumor out, a significant proportion of them die with locally destructive disease. So there's still a value to providing some meaningful palliation. And there is definitely a control benefit, as we saw in the LAPO-7 study with chemoradiation. And now as radiation has evolved, there's more opportunities. Palliative therapy can also be meaningful. And same with metastatic disease, palliative therapy, radiation therapy can be incredibly meaningful, and good collaborations with palliative care and medical oncology can really provide important impact for our patients. But in addition, oligometastatic disease may have a new opportunity, which I'll hope to touch on in a few minutes. So this is our playbook over the last years for how we've done SABR in pancreatic cancer. So what do you need? You need two main components if you're going to try to develop such a program. You need the clinical playbook. So in 2017, we had the PanCRS study open. This was a trial run by Albert Kuhn out of Stanford, and that became a gateway to really be discussing the role of radiation and exploring it experimentally for our patients and with our interdisciplinary program. I actually had a family member on this study when I was over in California at Stanford, and also a family member of one of the colleagues of my wife. And it was very meaningful to be on the other side of this study and then to think about how we can translate that to patients here. 2018, we had recruited Dr. Zay, our surgery chair, who was at UPMC for many years, and has been a huge kind of champion of helping work with us to figure out the best ways to incorporate radiation with surgery. We also opened up the phase 1, phase 2 dose escalation study through Galera that was recently published this last year, led by Dr. Taniguchi, who unfortunately passed right before the publication came out. And then we began our Pulsar experience back in 2020. And after that first phase 1/2, that led to a large international phase 3 where we enrolled 177 patients. This is the Greco-2 trial. And again, though that we were using dose escalated doses there at 50 gray and 5 fractions. So we also have to have a technical playbook, because how are we going to accomplish this? Well, when I first started doing some of these procedures, we were working on conventional LINAC with ABC deep inspiration breath hold, as well as started putting in fiducial markers so that we know exactly where the target is and where the motion is. 2019 to 2022, we moved to the TrueBeam LINAC with ABC, and we incorporated triggered imaging, because what we realized is that we needed to know for each breath hold where the tumor was in order to safely escalate dose. It added the Vision RT system in 2022, 2023 to the TrueBeam. And then in 2022, we introduced our MRI LINAC for adaptive radiation, as well as our Ethos CT-based LINAC, which we are transferring with Vision RT, and I'll talk more about that in a minute. So what's happened at our center over these years? Well, we went from 2010 to 2016, 2017, where in 2018, we treated more patients than the 7 years before that. And the numbers, even despite COVID, continue to be increasing as we develop useful and meaningful collaborations with our colleagues. So the technology to transform the treatment. So what do we use? Many are aware of the ABC system, which essentially you can set a threshold for the amount of air that goes in for each breath hold. So then the patient stops breathing. The problem is that just dictates how much air is in your lung. It doesn't necessarily dictate where everything else is. We also incorporated the TrueBeam system, which does have triggered imaging. So that means when we beam on, we can actually be looking at where fiducial markers are on the internal. So now we can do internal and external verification of position during an arc or during a treatment. And that also came with the RPM system, where you can track the breathing motion. Then the Vision RT system, the infrared monitoring of the surface for surface-guided radiation therapy. We transitioned to that. And then, of course, in these last few years, our center has been transitioning to adaptive radiotherapy. And it's very important for us to be considering carefully how we transition our treatments with these technologies, which I'll hope to touch on a bit. So motion is one of the most important safety considerations that I must say. A lot of people are really excited about MR linear accelerators. Part of it is because we can know the motion. But if you have a technology where you don't know what's happening in the motion, it doesn't matter too much if you can change the volumes. If your OARs are moving into the field, then you have potential risks. And the risks are real, and we see it, those of us that treat all the time: ulcer, bleed, and perforation of the bowel. And it never, always hurts whenever we have such an experience. You can see here on our Unity system, when we have a patient in a frame and pretty harsh abdominal compression, just looking at the celiac artery right here, you can see how much motion there is in that position. Therefore, bowel can potentially move in and out if you're not watching exactly where it is. So when we were working with our ABC system, we realized that we needed better technology if we were going to safely dose escalate. One of the ways that we realized that is we were using the Versa machine, and we were taking intra-arc cone beam CTs. And then you can take a look while we have the beam on and see where these fiducial markers are. Here's a fiducial marker right here. A lot of the time, the markers were perfect, clear, and pristine. So that means throughout that whole arc, we actually were right on, and each of the breath holds were right. But there were times where one marker would turn into 3 or 4. It might take 3 or 4 breath holds to get through one arc. So therefore, the breath hold that patient was taking was inconsistent. It is important to coach the patients, and we try our best, but it can be a challenge for a lot of patients. So what we did is we implemented intrafraction KVs and intra-arc KVs on our TrueBeam system, and that would be able to help us do more effective delivery of the treatment with deep inspiration breath hold. So we would use the ABC system, have fiducials implanted in the patients. For every image, we would take an image for every breath hold that the patient would take. We would turn off the beam if the fiducial markers were not in the right position, or we would not turn on the beam if we're not quite ready. And at this time, we were doing it with the TrueBeam 10x FFF, so we can get through quite fast, over 2,000 MUs a minute. We would give the patients oxygen, and they could hold their breath about 40 to 45 seconds if they're relatively fit. And we can do plans that were excellent with just 2 arcs. So sometimes we can get through a whole treatment of 8 or 10 gray in just 4 breath holds. And here's what it looks like on the TrueBeam when we're using the RPM system for the breath hold. The patient starts holding the breath, so we're doing surface monitoring. And then we turn on the beam, and you'll see the machine start moving, and we start taking the triggered images while the beam is on. And every 30 degrees, we have a triggered image. And you can see these 4 fiducial markers that are all in place. And as soon as we see those move outside of the 3 millimeter margin, then we turn off the beam. Or if the breath hold wasn't right, we don't even turn on the beam, or we turn off immediately. So this really helped us be confident when we were a bit nervous before that we could safely dose escalate, because we can know where the position of the tumor is when the beam is on. So the challenge and the transition to surface guided radiotherapy. Treatment on conventional LINAC was excellent. However, we needed internal and external verification, which hopefully I showed you. Sometimes those treatments, the one I just showed you on the TrueBeam, we would take many breath holds just to get the treatment done, because a lot of breath holds would get rejected if the ABC was not consistent. So therefore, this led to long treatment times, maybe 40 all the way up to 80 minutes, sometimes a little bit longer if we had a hard time. And it was really hard on the patients. So we need a strategy to transition. We also need a strategy at that time to transition to adaptive radiotherapy, where we don't have intrafraction KV monitoring, at least in the systems that we have currently. Of course, the Unity, you can actually use the BFFE MR sequence to look at the motion, but you can't do much about it right now. So this is kind of how we took the playbook for really developing and validating what can we trust on the machine. So can we trust the external and verify it with the internal, and only track the external? So the first step that we did, a lot of this work was led by Dr. Parsons and Godley, who are kind of the leads in our physics group, and I'll highlight some of our amazing residents and the work that they have done. We would evaluate the patients at SIM, and we'd do at least 4 breath hold images at different times after doing injection of contrast. And then we could look at the change in the position from breath hold to breath hold. Step 2 was to then also evaluate on the TrueBeam machine with Align RT. And this would give us a sense of the intrafraction and also be able to do intrafraction KV imaging so that we can correlate the external with the internal. And then step 3 is then implementation on the Ethos machine when we can do adaptive radiation, but we don't have each breath hold imaging. And we're currently in step 3, so I'll show a little bit of what we've been doing. So Dr. Domal has been really amazing at helping us evaluate some of these data with both deep inspiration and relaxed exhale from our simulations. And this is looking at a histogram of the deviation off of 0 in a deep inspiration breath hold versus expiration in 3 different dimensions. And you can see we could have quite a bit of variation with the deep inspiration, again, because the patient's strained. It's actually not so easy to do a consistent deep inspiration. With the relaxed exhale, you can coach the patients to just end a normal breath and stop there. And you tend to be much more consistent with the position that everything holds. These are some of the data right here, looking at the inspiration versus the expiration. And you can see if you were going to use a 5mm PTV, we were only off about 2% of the time with the expiration, compared to almost 20% in the SOUP-INF direction with deep inspiration. So what happens on the machine? So it takes time to achieve optimal breath hold, I had said, and we would like to make this faster, and we'd like to be able to monitor surface, of course, when we go to the adaptive treatments. Dr. Wong has done an amazing work in analyzing over 1,200 kVs that we took on the machine for our patients. And we would only beam on, I'd remind you, we'd only beam on when the fiducials were within 3 millimeters, but we were taking many kVs trying to get there. So here you can see some of the data, similar type of histograms with the ABC deep inspiration breath hold versus a surface guided on the Vision RT deep inspiration and deep expiration. It's hard to really see much of a difference. You can tell with the surface guided, it got improved. But when you quantify it here, you can start to see how the expiration breath hold has helped us. Both inspiration and breath expiration for the Vision RT has helped us get to a much more consistent state than where we were before. Here is what it looks like when we're treating on our Ethos machine. And you can see a patient is breathing and they take in a breath, or they exhale, and you can go ahead and see where they stop and end that exhale. And it can be quite consistent tracking this on the patient, which has been very helpful for our team and gives us a lot of confidence. I would say we struggled on the TrueBeam on when we would actually turn on and off the beam when we couldn't reproduce this. But with the expiration, it's much more reproducible. And that gives us the opportunity to really meet in our adaptive plans the guidelines, and also know that we're hitting the target as we want. So the future state, I know I only have about 2 minutes left, so I'll talk a little bit about adaptive radiation therapy and some of the things that we're going. What's great about adaptive, the new technology, is that we can adapt the treatment daily, and we can account for position and also account for motion. Both of those are critical. So we use the Ethos machine, which we have the surface guided radiation that we're currently validating, as I showed, for using the Vision RT. And one of the key things here is you have to account for time, because when we go to a lower energy beam, the time of beam on increases, so breath holds can be challenging. We also use the Unity MRI, which right now we try to reduce motion as much as possible, which can be quite difficult, but we're really excited about the motion monitoring system that's coming out, hopefully to our center in the next few months. So on the MRL, one of the things you can realize, even with even when you have a patient in a frame and with compression, you can still have a lot of motion. So this is a patient we were treating the liver, and we had over a centimeter, or about a centimeter and a half motion. So one of our amazing therapists, we can only do this with an amazing therapy team that is really up there with the technology with us. Melanie had the idea of, well, what if we add oxygen while we're doing compression? And we found that we were able to decrease the motion, and currently evaluating that prospectively, and hope to share that soon. So how does the technology and our approach impact patients with pancreatic cancer? Our ability to safely explore the benefits of radiation therapy with RT courses can be very fast, and also the radiation course has very low toxicity. And we can also personalize our treatment. And we believe that this can help extend survival and quality of life. If anything, quality of life, and we see it on a daily basis. One of these examples is our work in illegal metastatic disease. Over the years, we've had more patients come to us saying, I don't want chemotherapy. Can you radiate my tumor? And if you had up to 5 metastases, we did treat those. And we found that patients that got radiation compared to an institutional control, of course, retrospective, we had improvement of polyprogression free survival. And you can see we actually had multiple courses as long as it was only a legal progression for those patients. And there was a longer survival for these patients. Of course, it's retrospective. Where's the prospective data? Just at GI ASCO this year, we have the first prospective data that was presented by our friends at MD Anderson, and they showed in a small study about the same patients that we published a year and a half ago that when in randomization, they observed a progression-free survival benefit. So this is leading us to what we hope is a concept that will be approved soon for phase 3 for evaluating the role of ablative radiation to all sites of disease. So we're excited for people to hopefully open this up if we can get approval that we expect we'll find out in the next couple months. Can we personalize and adapt radiotherapy based on response? Many have heard about Pulsar from our chair, Bob Timmerman, and this is an example of what we might do. You could take patients in different scenarios, and if you spread out their treatments, their ablative radiation doses, you may have different things that happen between. So the benefit of this is you can reduce toxicity and you could potentially adapt or change your plan. Sometimes it's a patient that's palliative or high risk of metastasis, and therefore you actually stop all therapy. Other times it's because there's OIRs in the way, and maybe if you let some more time, you have lower risk of major toxicities. So we actually have done this in a number of our patients with GI and are looking forward to sharing our experience soon. And we first started it for the patients that had recurrence after SABR. So now doing this for 7 years, we have patients that say, I'm not going back on chemotherapy, and they have recurrent disease after SABR. And we know that after chemoradiation, SABR is appropriate, but could you re-SABR? So the way we cautiously started was doing once a month pulsar treatments and have had actually a good response. It could also be a very useful approach for definitive treatments for cancers that involve the bowel. But of course, you got to be very careful about the risk of toxicity. And of course, there's other palliative directions that you can take this type of treatment. So we're excited to look at this in the future and see what can come. So just a brief summary. I know I'm a few minutes over time, but thank you so much for hearing me out. I think that the future of radiotherapy for pancreas cancer is very bright. Just as systemic therapy and surgery are rapidly evolving, so is radiation. The technology has driven many transformations, and the next era is going to be personalized and biologically driven radiotherapy. The future state for Pancreas SABR is looking promising, in my opinion, and we continue to optimize our technology as well as how we deliver the treatments and expanding to new areas of treatment that could provide meaningful benefit for our patients. So with that, I hopefully had given some recognition to a lot of people, but there's a huge team at UT Southwestern that's been working with us. And here's a picture of our team at the Purple Stride, which is in just a week and a half away. So we're excited. And we encourage everyone to join Purple Beam teams across the country. Thank you.
Okay, before I start, thank you so much to Dr. Aguilera for that great talk. I learned a lot. Appreciate all of those great comments and the great work that you're doing. I appreciate the opportunity to be here today. We're talking about improved efficiency and accuracy in hypofractionated pelvis treatments using SGRT. One of the things that struck me as Dr. Aguilera was speaking was one of the adaptive slides where it said, if we can't compensate for motion, then it's pretty much all for nothing. That sums up my talk. I think I could pretty much quit there and walk away. But at any rate, we'll be looking at the use of surface guidance in the context of pelvis treatments and specifically in hypofractionated treatments. And I've got a disclaimer to start with because I had the benefit of going over this topic with several colleagues and also a couple of friends. And more than one time, a person was skeptical about whether or not SGRT actually has a part to play in pelvic radiotherapy or pelvic hypofractionated radiotherapy. And I think that's because of a common misconception that somehow the use of SGRT is being proposed to eliminate or substitute for IGRT. And of course, that is completely not the case. We who are avid users of SGRT, who have adopted it for every patient, every fraction across the board, because we have been convinced by the data that our treatments are higher quality and our patients are safer because of its use, know that we're using IGRT targeting as our gold standard, of course, but there are a host of benefits that are added to the treatment workflow by adding in surface-guided radiotherapy into our modern radiotherapy workflow. And that's really the content of the presentation today. We're focusing on, in this presentation, the use of SGRT for more consistent and efficient patient setups, and also accurate intrafraction motion monitoring on the patient's external surface contour, so on the patient's macroscale, where even imperceptible motion, as it's judged by, for example, the CCTV or in-room monitors, even imperceptible motion can cause catastrophic effects in the context of radiotherapy, small margins, particularly for SBRT. There are other ways that surface guidance is blossoming right now. It's a very exciting time to be involved in the various types of SGRT technology that are being rolled out right now. There are aspects of simulation, treatment planning, patient ID, all kinds of ways that surface guidance may additionally improve the safety and quality of the pelvis radiotherapy workflow, but I'm not specifically discussing those other aspects today. So the journey toward this particular talk started way back in really 2014, 2015, when in the clinics at Northside in the Atlanta, Georgia area, we started to implement SGRT. And in the very beginning, as I think is often the case with many clinics who are implementing this technology, SGRT was kind of viewed as a special procedure thing. It was something that would be used for deep inspiration breath hold for our breast patients, perhaps to give better intrafraction motion monitoring for intracranial SRT or SRS patients, but it was kind of limited to that. And from the feedback actually of some of our most adept and skilled therapists, we started to learn that there were way more benefits here potentially unlocked by expanding our use of SGRT. And so we started looking at, well, what does that really mean? What can this do for our radiotherapy workflow and for our patients if we expand its use to basically everything? And so in addition to a breast study that we published in 2018, we also collected a lot of information on pelvic RT. And from our institutional study in 2018 found that in approximately 400 fractions of pelvic RT, where we set up the first half of those fractions for each patient using skin marker triangulation, versus the second half of those treatments for each patient being set up with surface guidance and doing the very best that we could do to minimize variables, that is using the exact same treatment team and those sorts of things, we found immediately that there were very large benefits to broadening our scope and our use of SGRT for more common radiotherapy techniques. We found reduced and more consistent setup time, somewhere on the order of 15 to 20% less patient on the table time. And not only less time on the table, but across the board, much more consistent setup time. We've all been in those situations where particularly difficult patients, often particularly large patients, situations like that, make it very difficult to set up consistently and efficiently. And we found that by expanding SGRT to every patient, every fraction in the context of pelvis RT, we were able to reduce those times and bring down the standard deviation. That is, make those setup times more consistent. We also found, upon taking, as I mentioned before, the gold standard of our IGRT techniques, which in these cases is often cone beam CT, that we would compare the initial setup position found by skin marker setups, and then of course imaging the patient via CBCT, to the magnitude of the shifts that we found after setting the patients up with SGRT. and then comparing the intended position to the actual position via CBCT, and found that our shift magnitudes were reduced by approximately half for our pelvic RT patients. And that had more than just academic information for us, because as we had, and I'm sure that many of your institutions have the same, some threshold that says that beyond some certain shift magnitude, you have to repeat your imaging before treatment. And so we were able to drastically reduce the number of times that we had to repeat imaging before treatment because of our more accurate and more efficient setups using SGRT. So less imaging, less time for the patient on the table, discomfort for the patient on the table, and drastically less imaging dose because of this expansion of SGRT. And that falls in line, that experience that we had falls in line with several studies that have now been published in peer review literature. Just a brief summary here, and you'll be able to look at these references in the handouts. But a 2023 study of the NHS at University Hospital of Southampton, they reported 44% reduction of patient in-room time. Oh, hold on just a moment, I've lost my slides here. I'm hoping you can still see my slides. A 44% reduction in patient in-room time for prostate patients because of implementing SGRT for patient setup. Another study in 2023 by Atrium Wake Forest found 55% reduction of patient in-room time, 80% reduction in fractions requiring reimaging, and elimination of skin marks or tattoos for prostate patients due to the use of SGRT and postural video. And that seems to be the trend. We're hearing this more and more, and this is true across our particular cancer network at HCA, that more and more clinics are able to move to completely markerless, completely tattooless setup because of the use of SGRT. Also, a 2023 published study in Nature Scientific Reports found that SGRT patient setup for pelvic patients was more geometrically accurate and 18% faster than similar setup times and setup accuracies by laser alignment to skin markers. So that's pretty consistent data across many institutions and many patient populations with the implementation of surface guidance in the context of pelvis RT. A couple of quotes that bring that home here from the study in 2023 in Nature. SGRT opens the possibility to reduce the number of CBCTs while maintaining sufficient setup accuracy. The advantage is a reduction of imaging dose and overall treatment time. And another quote here from Advances in Radiation Oncology 2023, the quality of patient positioning before radiotherapy treatments has been optimized by using SGRT without additional imaging dose. SGRT clearly reduced inefficiencies in the patient positioning workflow. You have to remember before we go on from all of that data, just a little bit of discussion here before we talk about accuracy, that those improvements in efficiencies, the reduction in patient in-room time of therapist in-room time, that has a whole cascading impact on the entirety of the radiation therapy treatment. Not only does it improve the comfort of our patients, reducing the time that they're actually on the table, we know, of course, now from multiple peer-reviewed studies that time on the table and patient comfort is directly related to geometric accuracy and targeting. So that the longer the patients are on the table, the more they tend to squirm, the more they tend to move out of the intended position, which once again, oftentimes we would completely miss if we were relying on visual cues from in-room monitors or anything like that, that does not have the millimetric or submillimetric accuracy of surface-guided RT. We shouldn't neglect the frustration component about this too. As we mentioned before, many times these pelvis treatments, because setups can be quite difficult, it's a source of frustration for the therapist, it's a source of frustration for the patients when they have to go in and out of the room multiple times, set up, fix the rotation, image again. Many of us have been in those situations where the treatment just starts out hard and gets harder because the situation tends to devolve as frustrations get high and patient comfort decreases. So there are all kinds of blossoming benefits from improving the efficiency of these setup times and reduction of the patient in room time by implementing surface guidance in these contexts. For the sake of time, we'll leave that there. Let's talk about accuracy benefits. of SGRT in the context of pelvic treatments, and specifically in the context of SBRT. So besides the fact that we have now proven through many peer-reviewed studies across the years, more accurate setup leading to reduced in-room time and reduced repeat imaging for patients, SGRT has also continuously demonstrated accuracy improvements by real-time patient monitoring, leading directly to reduction of motion-induced errors. So here again, going back to our own kind of institutional studies for ourselves, in 2020 and 2021, we took a look at our institutional numbers around lung, abdomen, and pelvis SBRT. And what we found was basically that 7 to 10% of our SBRT patients, depending on the particular anatomies that we were looking at, 7 to 10% of those treatments were halted based on the real-time information that we were getting back from the surface guidance system saying that some kind of motion had taken place. I have to stop there and say, especially when the SGRT system is relatively new in the radiotherapy workflow, this can really be a source of frustration, because if you have a treatment team, whether it's therapists, physicists, physicians, whatever, in the context of SBRT, that are not convinced yet, which this baffles me because we have data now going back to the early 2000s proving that this is true, but there are still the skeptics out there that somehow don't think that these systems work or don't believe the information that they're spitting back to us in real time. This can be a real source of frustration when apparently on the cameras everything looks fine, and yet the SGRT system is saying that the patient moved. And so we have to stop and we have to image, unless of course we're using other RGRT methods that are taking pictures during treatment, like triggered imaging that Dr. Aguilera mentioned before. I know the ExactTrack system has that capability as well. But at any rate, 7 to 10% of these SBRT treatments were halted based on the information that we were getting back from surface guidance. And we typically found that these patients had to be not only rescanned, of course, but also shifted because the geometry had changed. At least one study, which is a really fantastic study, found similar and more detailed results than that kind of in-house study that we performed. This is the 2020 paper in the JACMP, use of surface-guided radiation therapy in combination with IGRT, of course, for setup and intrafraction motion monitoring during stereotactic body radiation therapy treatments of the lung and abdomen. And in that study, they found that out of 335 SBRT fractions treated, 34 fractions, and so roughly 10%, and 25 separate patients, telling us that some patients move more than others, exhibited patient movement that was beyond their institutional tolerance, which in that case was 2 millimeters, as observed using SGRT. So they also found that 10% of their SBRT patients moved on the macro scale, that is by looking at the 3D model of their external surface contour as created by SGRT and monitored in real time, telling them that about 10% of their patients moved beyond institutional tolerance based on their external anatomy. After IGRT, figuring out what's going on here, they found that the vast majority, 74%, of those fractions resulted in shifts that were 2 millimeters or greater based on cone beam realignment. And here again, we have to stop and pause because this is so important in the context of stereotaxy, right? I guess we could say, I would not argue this actually, but I guess we could say that, 10% or 7% of treatments that a patient actually moves enough that it's beyond tolerance and requires reset up based on cone or shifting based on cone beam, that maybe that washes out in the context of conventional radiotherapy, but that is not the case in the context of stereotactic radiotherapy, especially in the context of prostate SBRT, where, as with almost all anatomical sites, the number of fractions is being reduced, it seems, by the year. Of course, the most common prescriptions are somewhere between 35 and 50 gray and 5 fractions, but we now have multiple randomized clinical trials looking at 2-fraction prostate SBRT, for instance, 2 shots of 12. We also have multiple peer-reviewed papers demonstrating the capability of treating with around 19 or 20 gray in one fraction for prostate SBRT. So in those contexts, we go back, look at this information again, look at it a little bit more freshly and say, I cannot emphasize this slide enough. Because if our patients, 10% of them, whatever, potentially are moving somewhere around 2 millimeters or more, that is radiation going into your organs at risk that you cannot take back, especially in the context of SBRT. There's a fantastic talk by Dr. Robert Timmerman on the AAPM virtual library. I commend to you that he talks about these radiobiological effects in serial and parallel organs, and he happened to touch on some of this data having to do with rectal toxicity in the context of prostate SBRT, and basically found a fact and figure that I'm sure most of you already know and have already seen, that the volume of the circumference of the rectal wall that receives a particular dose, in this case 39 gray, has very high impact on the high-grade delayed rectal toxicities that are observed in these patients. That is, patients who end up with holes burned in their rectums, that end up with colostomies and things like that. And if you take a look at this particular figure from the publication, of course, that has to do with that topic, you can see, oh, I don't know if you can see, I can see on my screen, maybe you can see it too, the green 39 gray line in a case where on the A side, demonstrated grade 2 and grade 3 rectal toxicities for the same prescription, where on the right side, you have a similar patient that 39 gray line is much tighter. It's not covering as much of the circumference of the rectal wall and did not demonstrate those same toxicities. This is just for illustration purposes, of course, but those two green lines are not very far apart. When we're talking about patient movement that could be 2 millimeters or more, that could make all the difference in a patient who is actually treated well for local control, or a patient that does not gain the local control that they need, or even demonstrates high-grade problems with the rectum due to these supposedly curative delivered doses. 2 millimeters is small in the context of patient movement on the macro scale in our experience. We have multiple times found situations where patients, because often, especially for prostate SBRT, we're dealing with full bladders, other types of things which make these patients very uncomfortable on the table. And because they're restricting their muscles or they're relaxing or something like that, we can see 6, 7, 8 millimeter motion that we would not detect on the in-room monitors at all if it were not for surface guidance. And now, of course, especially for stereotactic treatments, introducing an 8 millimeter shift is enormous. We've basically missed the whole football field at that point if we've missed an 8 millimeter motion. So again, the accuracy benefits that are brought to us in observing and real-time monitoring of the patient's external surface contour cannot be overstated in these contexts of pelvis RT, and especially hyperfractionated pelvis RT. So just a couple of things here at the end of the talk. I'm not even exactly sure how many minutes I have left, but some implementation considerations for SGRT in the context of pelvis RT. Obviously, as is true with every other anatomical site as well, for your SGRT program, consistent simulation, consistent setup, consistent SGRT region of interest drawing. These things just have to be like clockwork down the board. Everybody's trained the same, everyone's following protocol. All of these things are set up the same way, or you will not get consistent results that show these improvements. So many institutions are using this kind of loincloth technique where the patient, for modesty reasons, is able to keep, you know, some level of coverage using a sheet. But then in that setup, of course, we're able to do a region of interest that covers the anterior portion of the patient and bilaterally on the hips to give us a very good coverage of what's seen by the cameras, thousands, if not tens of thousands of points on the patient's external contour that are being monitored in real time. If these are not done well, if they are not done consistently, if you're clipping the sheet, if you're clipping immobilization devices, all of these benefits go out the window. So the importance of all of the staff being trained consistently and following the protocols and policies and procedures that have been written for your particular technique at your particular institution are absolutely vital for implementation of SGRT programs. So consistent training, complete training, documented training of the entire treatment team is a great first step. That is setting these written policies and procedures up before proceeding. When you actually implement them in the clinic, putting some thought here and using a multidisciplinary clinic and looking at the vast amount of literature that is now available to us, thankfully, through both peer-reviewed literature and white papers from various vendors to help us make these decisions and build these policies. If you are not aware of it, there is a really fantastic Royals Radiation Oncology Instant Learning System report. I think this came out in 2021, if I remember correctly. It's specifically dedicated to surface-guided radiation therapy and how to safely implement an SGRT program based on the incidents that were reported to the fantastic Royals system. If you search back in the SGRT library, there are multiple talks about SGRT, that is the SGRT community library. There are multiple talks that have to do with this kind of niche of patient safety and quality. And a shameless plug, I gave a talk on this, I don't know, a couple of years ago that we specifically went through this, the recommendations of this report, but absolutely vital source of information for you in your clinic if you are thinking about or you currently are implementing SGRT. And one particular quote I'll leave you with from that publication: surface imaging is a tool that has the potential to be value additive and act as a safety barrier. However, its value is dependent on the way in which it is implemented, and care must be taken when implementing any new technology to prevent the introduction of new error pathways. And that's exactly what we have found across our clinics for building an SGRT program, for expanding that SGRT program to every patient, every fraction, including those patients who are receiving stereotactic body radiation therapy. So thank you very much for considering all this information. I'll hand the talk over to the moderators.
Here we go. So we'll have the moderators and speakers back on screen, and they can start the Q&A session.
Thank you so much to both of our speakers today. If you have any questions, please be sure to enter them into the questions box. I unfortunately cannot see that box at this moment, but while we're pulling that up, I do have a few questions, one for each of our speakers while we're getting that, getting the access to that question box. So for Dr. Aguilera, you mentioned one of the first things you said is that organs at risk are an issue kind of regardless of technology. If the stomach or the duodenum is going to be abutting your tumor, it's an issue regardless. So I just wonder if you could speak a little bit more. You have both ethos and the MR-Linac available at your institution. How do you choose what modality is best for which patient? What technical considerations do you think of when approaching a patient, and how best just to treat, what modality basically to treat them on?
Yeah, so it depends on the tumor and the location and how much motion there is. We're trying to use the MR-Linac more, particularly in areas where we're further from the bowel or there's not a lot of motion. Areas where there's not a lot of motion are really close to the base of the mesentery, superior mesenteric artery and celiac artery. For our post-op cases, our patients who have recurrences after a surgery in the past, there's usually not a lot of motion of the target. So in that case, the MR-guided treatment can be very good. But if the tumor is in the body, which oftentimes, in particular, more anterior in the body or tail or in the head, even the uncinate, that can move a lot and be very close to bowel, in which case having that breath hold is really critical. Now we'll see what happens once we get better motion management in our MR-Linac. So the ethos or the TrueBeam are the routes we go when we need the breath hold and we need to be really precise.
Thank you for that answer. We have a couple questions coming into the chat, but I will just pose one more question for Dr. Bailey while we wait for those. So excellent talk on SGRT. Question for you. It all sounded very promising, and I'm sure that it is, but are there any technical challenges or patients, any limitations? Are there any patients for which you struggle with applying surface guided treatments to? Are there any downsides that you can see or discuss?
Yeah, thank you. There's difficulties with the implementation of this technology, like with implementing any similar technology in the treatment room. There are so many variables that can just make things very tough, right? The non-compliant patients, the patients that can't be still, the patients that for whatever reason, it just seems like it's taking us a full hour to get through treatment. I will say that in the context of those very difficult situations, typically SGRT, if we listen to it and we're following it carefully, which all of that is predicated, of course, and I really can't emphasize this enough, on appropriate QA being done, that the QA protocols are being followed so that the information we're getting from the system is actually accurate. And again, as I mentioned in the talk, the training, the entirety of the therapy team is actually trained to use the SGRT system in the same way. If those two things are not true, then a lot of things can go awry. But assuming that those things are the case, what we have found is that even in the most difficult treatment scenarios, SGRT is a benefit to us because we're able to see those types of motions, reduce imaging typically, even determine from SGRT, and this does sometimes happen, even determine from the data we're getting from SGRT that a patient just is not a candidate for the type of hypofractionated treatment that we're doing because they cannot stay still or whatever, right? So there are other difficulties with SGRT that aren't so applicable in the context of pelvic SBRT. That is things that, for example, include the camera and make problems for us during treatment scenarios. But at least that gets you kind of started to thinking about the problems that we have and the ways that we mitigate them with these systems.
Thank you very much. And now I'll turn to some great questions that are coming in for the audience. The first, our audience thanks you for both of your talks. How do you choose between exhalation and inhalation breath hold treatment? And do you ever do free breathing gated expiration treatment instead of breath hold? I suspect this is directed to you, Dr. Aguilera.
Yeah, so I kind of showed the evolution of our experience. We weren't able to do expiration breath hold until we dropped the ABC. We wanted to make sure that the internal and external verification was good. We dropped the ABC, moved to Vision RT, and we're confident in it. Then we moved to expiration. We pretty much do expiration now on most of the patients. They can usually tolerate it. Maybe a little bit harder for the breath hold. It's weird doing that breath hold, but they can get through it. The other question about, what was the second one?
The second part of the question was, do you ever use free breathing gated expiration?
Yeah, free breathing gated, we've never been big believers. I used it at Stanford in the past, but at UT Southwestern, we have not made that decision to go to gating, though that is a potential option and the technologies afford that. And then free breathing, it depends on motion. Sometimes we will do free breathing if you have a target that's not close to OAR, but we have to be cautious.
Thank you. And then just moving down the list, we unfortunately only have about a minute remaining, so I will direct this last question to Dr. Bailey. Is SGRT able to detect changes in bladder fill from CT to treatment due to surface anatomy changes?
That's a really interesting question. Short answer is yes. The longer answer is I'm not sure how reproducible and accurate that is. We are finding that especially in the pitch dimension of rotation, we are able to tell sometimes, maybe not more often than not, but sometimes that a patient's bladder filling is not what it was intended to be. We have never done a systematic study of that. That's just anecdotal, that we often find that the pitch is off when the bladder is not what it should be. So the short answer is yes. The longer answer is we need to do more study on that to tell whether or not we can actually predict a patient's bladder filling optimization just from the surface guidance comparison to the reference image.
Thank you. We have reached the end of the hour. This has been a really informative hour with both of you. Thank you so much, and we thank you for those who have joined us today. We look forward, the RSS looks forward to seeing you all at the next session.
Thank you.
Yes, thank you so much, Drs. Chalebi, Aguilera, and Bailey, for taking your time to support our educational mission. And we also want to give a thanks to Vision RT, who was able to support this grant through an unrestricted, or this webinar through an unrestricted grant. Just one final reminder to our attendees is that if you're looking for CMEs, you will receive an email with instructions on how to obtain your CME certificate. Again, we encourage non-RSS members to consider joining the RSS. There's lots of benefits available to you in addition to free CMEs that are listed on our website. And last but not least, we just want to do an advertisement for our next webinar, which will be held on Wednesday, May 8th at 12 p.m. Eastern Time. The title is Stereotactic Radiosurgical Thalamotomy for Treatment of Essential Tremor. And details regarding registration links will be available on our website in the next 24 hours. Thank you again so much. We appreciate your time and have a great afternoon. This will conclude our webinar.